Part of the mindfulness module is an introduction to DBT, which was created by Marsha Linehan. She was a professor of psychology and psychiatry and behavioral sciences at UW, University of Washington in Seattle, and director of the behavioral research and therapy clinics related to dialectical behavior therapy. And she created this model as a result of her own mental illness. She has put out her memoir and mentions it in a few videos. So in 1993, she wrote a book about CBT treatment of borderline personality disorder and the first edition of the skills training manual for treating borderline personality disorder, which was revised in 2014, and a book of updated handouts in 2015. This is what the books look like. So DBT groups, anywhere you take them, are going to be based on these primary skills coming from these manuals. There are links in my trainings or Google slide presentations to many of the handouts and worksheets from that book. So now let's talk a little bit more about borderline personality. And these are just a couple of notes. What is BPD? It's a serious, long-lasting, complex mental health problem. People with BPD have difficulty regulating or handling their emotions or controlling their impulses. They're highly sensitive to what's going on around them and can react with intense emotions to small changes in their environment. What causes BPD? As with other mental health disorders, our current understanding of BPD is that a person's genetic inheritance, biology, and environmental experiences all contribute to the development. How is it diagnosed? A physician or psychiatrist or a registered psychologist or a licensed clinical social worker can make a formal diagnosis. The first step towards diagnosis is often with a family physician or emergency department of a hospital. If there's enough reason to be concerned, the family physician can make a referral. Signs and symptoms. The types and severity of BPD symptoms may differ from person to person, and symptoms can fluctuate over time. Common symptoms include intense but short-lived bouts of anger, depression, or anxiety. Emptiness associated with loneliness and neediness, paranoid thoughts, impulsive and harmful behaviors such as substance abuse, overeating, gambling, or high-risk sexual behaviors. Non-suicidal self-injury such as cutting, burning with a cigarette, or overdose. Volatile and stormy interpersonal relationships. Treatment usually involves education, with discussions on what is known about BPD and its causes, what kinds of treatments are available, how to self-manage, and how to prevent relapse. Psychotherapy or counseling on an individual and group basis. Evidence-based treatment with most research data is dialectical behavioral therapy is what works. Prescription medication for specific symptoms of borderline personality disorder, such as mood swings or anxiety. So technically, medication doesn't treat a personality disorder. It treats the comorbid axis 1 mood symptoms. So keep in mind that BPD is also the acronym or abbreviation, I should say, for bipolar disorder. So that is sometimes confusing. So let's look at how does this diagnosis overlap with other diagnoses. First of all, here's kind of a look at how what the prevalence has been of different mental health disorders. And I had found this mostly because I was interested in how high phobias, and particularly social phobia, is. It's more prevalent than depression. And then you see a few of the personality disorders amidst the mood disorders here. Avoidant personality being the highest, reported to be 5.2%, and borderline down at 1.6%. dysthymic, which is not a personality disorder. There is a depressive personality disorder, I think. Anyway, maybe not. Obsessive compulsive disorder also has a personality disorder. They don't list that. Antisocial, and yeah. So this is another, I like these pictures where it's sort of like, hey, disorders are not isolated, that they overlap. So for example, someone with social anxiety, shyness, or avoidance could have, it says, a normal amount that could be transient, comes and goes, but it is something that is common to all these other disorders. Happens to be common to autism spectrum, schizophrenia, body dysmorphic disorder, panic disorder or agoraphobia, social anxiety disorder. And it becomes a disorder when it is more consistent and more affecting the person's functioning, so causing impairment, distress, or both. Which can overlap with these here, obsessive compulsive disorder as well. And then note that major depression overlaps with a lot of these. They're often comorbid as well, which just means you have two, you're a double winner if you have two mental health diagnoses. Another slide talking about the causes. Masterson's theory, the child tries to separate and mom withdraws love. Child clings and mom rewards. Child's unsure of affection. Fathers may be distant, alcoholic, or unavailable. Neglect of the child. A split occurs, the good me and the bad me. Invalidating chaotic environment. No object constancy or consistency in caregiving, and developing a low tolerance of ambivalence. 75% of clients with BPD are women and victims of childhood sexual abuse. But keep in mind that men are chronically underdiagnosed or misdiagnosed. So here is another symptom overlap diagram where you have the symptoms of BPD in green, the symptoms of PTSD in, what do you call that, like magenta or purple? Anyway, and then something that's called CPTSD, which you probably know is complex PTSD. And look at how that basically is the connection between the two. And that trauma is inordinately correlated with BPD. Not always, but frequently. And then this is just, again, remember that BPD, meaning borderline personality disorder, can overlap actually with bipolar 2 disorder or cyclothymic disorder. You can either have one or the other. They're very close in diagnostic criteria, or you can have both in that little overlap. The overlap also meaning, like, what do these two diagnoses share in common? Impulsivity, affective instability means your emotions, inappropriate anger, recurrent suicidality, and unstable relationships. So last one, this is an interesting overlap between BPD and ADHD. That ADHD has a high component of emotional affective instability. There's interpersonal deficits and impulsive behavior in both. And then there's certain diagnoses that are differential, that they one, is definitely related to only one of the diagnoses and so on. So being referred to DBT, dialectical behavior therapy, does not mean that you have a borderline diagnosis, partly because it takes a long time to be given the diagnosis, and there are a lot of rule outs, and many people, I would venture to say almost most people have personality disorder traits, but it takes a lot to get given the full diagnosis. And it also has to do with how much those traits impair your functioning in your life. But we could assume that everyone in group has a borderline personality disorder and not feel any stigma or shame about that possibility. All right.